Welcome to the Dear Doc podcast, where we will discuss the business of running a dental practice with a panel of experts. Now, your host, Dr. Christopher Hoffpower.
Hey guys, thank you for joining us for another episode of the Dear Doc podcast. And we are being live cast right now on the Business of Dentistry Facebook group. I want to thank our guest today, who probably needs no introduction, but will get one anyway. Arun Garg is one of the original gangsters whenever it comes to education of dentists, particularly in the advanced surgical techniques that many of us use today. I have learned a ton from him myself, and I can't imagine going another year and not learning more from him, because he's always got something new that he's bringing to us. And I want to take the time to personally say thank you, both as an educator and as my friend.
Thank you.
So, Arun, how are you doing today, my friend?
Well, as under the circumstances, I'm doing great. But is with that qualified under the circumstances.
Probably the most honest answer that you could give in this day. But I asked you here because I know that you personally have been, I hate to say coaching, because that's not really what you're doing. You're just visiting with people and helping them out and helping them to get through these times and advising them on everything from patient processing to personal protective equipment to just strategies business-wise coming out of all of this. And you said yourself, you don't claim to be any kind of expert in, restarting your practice after COVID. Good God, anyone who does that is a moron, because nothing like this has ever happened before. But you've been through a few of these. I mean, you've been through the AIDS crisis. You've been through several recessions. And I just thought that you had a beautiful consolidation of knowledge that is just really going to help a lot of people today. And so I asked you to come on and just talk with us. And so without further ado, I'm going to shut up and I'm going to let you give yourself the introduction that I know you don't need. Tell everyone who you are and what you do and what your qualifications are to speak on this subject.
All right, I won't bother with the introduction and such, but I'll tell you what happened is once I graduated, I went from University of Florida. I went down to Jackson Memorial Hospital to do my residency. And when I was a resident, that's when the whole AIDS thing came out. And yes, I've been around that long. I know I look a little young to have been around that long, but I have. And the whole AIDS thing. And at that time, we didn't know. I mean, we didn't know how do infections happen. I mean, today we know it's blood-borne or semen-borne or saliva-borne. But at that time, we didn't know. Can you catch it from a sneeze? Can you catch it from someone touching you? And Jackson Memorial Hospital, being the third busiest hospital in the country, and being Miami, we got a lot of folks were potentially infected, and we're, ourselves, the faculty and the residents, how do we deal with this? And we got through it, and we came up with strategies. And at that time, there was a thing like, let's open a separate clinic and put the HIV folks in that separate clinic. And then it became declared in the U.S. a recognized handicap. So you couldn't, discriminate based on a handicap. Right. And so, like, you can't take people in a wheelchair or, people who were deaf or something, put them in a separate clinic. So they had to be seen in the same clinic. And so, okay, well, that idea, I guess that went out the window. And so we initially tried that separate clinic for them, Right. And then we said, okay, then the same clinic, same waiting room, we're going to have to upregulate everything for everybody. And we did. And survived. And it was scary back then. Sometimes a resident, they'd get an accidental needle stick, and then you don't know if the patient's HIV positive or full-blown AIDS or what necessarily, and you'd have to ask them, and what if they didn't tell you the truth? And you can't just draw blood on them, even in the hospital environment, to test them. You'd have to get their permission. And so we'd have to get permission from them, and sometimes they would give it, and sometimes they wouldn't. And if they wouldn't, it was, and I remember residents fortunately, I didn't get stuck like that, but I remember several residents I got stuck, and the recommendation back then was, then you can't, you got to use, prophylaxis with your partner for 1 year. You got to do this, you got to do that. And, residents are young, they're in their 20s, and you're like, what? I can't do what for a year? And we got through that. And then, of course, as you said, is economies have gone up and down and such. And then most recently, I've been in private practice. I left the university environment after 20 years there, and I've been in private practice. And so now I've got to think about not just those types of things, but now also financial issues. Because at least at the university, I was protected financially. I got my paycheck, boom, 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 boom. Like the folks right now, there are folks who are getting a regular paycheck. Not in the dental field, but in other fields. Mm-hmm. Is people you see on the chat rooms, they go, the government workers, they're getting a regular paycheck. Yes, they are. And as are university professors getting a regular paycheck. And so there's a lot of folks who financially it has not impacted actually, maybe. And but now in private practice, so I've dealt with that as well. And
there's a point you make there that I think is very poignant, and maybe some people aren't catching. When you have a shared reality with someone, there's understanding. If you were another dentist who's been affected by this, you automatically have a shared reality. You already have an understanding, something that links you to another dentist who's done this. But in a very real way, anybody who is not being affected in that same way with a business shutdown or what have you, they don't share our reality. And so the hardships that we have are not immediately evident to them. I don't know if I'm making that point clearly enough, but I think that's kind of one of the things that you were bringing out there.
Yes. Yeah. And even in dentistry. And what I did is I jotted down, I just thought about, because, during all this time is I've been talking and chatting with colleagues and friends and alumni from my courses and such. And what I realized quickly is that every single person I talk to, their situation is completely unique, even though we have the shared reality, but they're still completely unique. And I said, well, okay, 100,000 different realities, but let's group 6 different people. Okay, and I'll give you 2 extreme examples just right off the bat. Is Andy. Okay, Andy is probably in his late 60s or early 70s. Mm-hmm. Andy was Affordable Dentures franchisee, and that franchise you normally get about $1 million a year gross revenue, but he was the top producer in the country is for them, and he was producing $4 million a year. Mm-hmm. And Andy had scheduled to sell it to corporate, like when McDonald's franchisee sells to corporate. And this is real story, is that Andy had scheduled back in September, October. Okay. And they closed on it in about the end of January. Mm-hmm. Now, the part he didn't say, and I didn't need to ask, is how much he got for it. But as you and I know, usually it's about 60% of annual gross, maybe 100% of annual gross from corporate. So maybe 2.4 million to 4 million, someone in there. Let's say $3.5 million. Okay. Mm-hmm. So if he just got a lump sum of cash, $3.5 million, and he's late 60s, early 70s, has been earning his entire career, and he was there for the golden years of dentistry. So he's got savings and stocks and houses. He flies his own plane. He's got planes. He's got cars. He's got one child, a daughter, and she's.
I don't think Andy's going back.
Yeah. And so his reality, even though he's in dentistry, might not be the same as me and you or someone else. So he's got one daughter. She's very successful, is employed, is married, her husband's employed. They don't need money. They don't need college money from him. So I told him, I said, Andy, you got 2 choices. Okay. Either you just say, hey, I'm gonna go fly around my plane. Okay. I'm going golfing, I'm going fishing, and that's it. Or what you do is right now, because what's probably going to happen is there's going to be other extreme folks that didn't have the money he had and have to give up their practice. And we'll talk about those.
Absolutely.
Folks. And those practices will probably sell for pennies on the dollar. And at least, if not pennies on the dollar, 25%, 30% less than what they were in January. So you can take your $3.5 million you got from this practice and probably another $3.5 million you got saved from before, or $4 million or $10 million, and go in a super practice for $500,000. And you got the clinical skill set, the mindset, the business mindset to grow it back up for as many years you know to, and then get an associate in there. Okay, so his reality is different, even though he's in the same field. And
so then I'm gonna ask you before we go on to another person that you've been talking to. What is your feeling about what percentage of dentists are going to close business after this?
I hate to say it because it's so depressing to talk about, but I mean, as you and I know, it's not going to be 0%. Right. Because I mean, I know 1 or 2 examples, I mean, I'll share one of them with you was a dental assistant. Okay. is, and if anyone thinks I'm referring to them, I'm not, okay? It's kind of not a person, it's an amalgamation of several people. So if someone says, hey, he's talking about me, no, I'm not, all right? In Andy's case, I was talking about Andy, but this I'm not talking about Andy. But was a dental assistant for many years. And so went back to dental school later in life, all right? And so now later in life is a graduate and then spends 8 years in the US Army. Great service for, is our country. Leaves there and just starts a private practice 6 months ago, okay? So
damn.
now maybe not the same age as Andy, but is not 20, not in the 20s. Okay. Has teenage kids, okay, is the sole breadwinner of the family. Okay. And built a gorgeous office with all the accoutrements, with CAT scanners and CEREC machines and Millennium lasers and. Okay. So probably over $1 million in debt, and open January, and so 0 patients. Okay, and this debt, and teenage kids, and the sole breadwinner of the family is, and it's a complete different situation than. And the advice I would give there is, if your debt service was 10 years before going into this, now it's going to turn into 20 years. I mean, you'll be paying debt on this practice in your retirement years.
Absolutely.
And you're going to be stressed the whole time. So my advice would be it kind of sucks for the people that you got the loans from, but declare the bankruptcy and walk away from that $1 million.
Absolutely.
Okay.
Well, and I think that's a very reasonable thing to do. Yeah. I think we're going to find that there are going to be a lot more bankruptcies amongst dentists in this time. I mean, even the best of us who, we save 3 or 4 months worth of operating costs and worth of personal costs. This hurts. But I myself, I always save 3 months.
Yeah, but this is 3 or 4 months right here. I mean, we say 3 months.
Exactly.
And this darn thing is, if it extends on 3.5 months, even a 3-month guy is yeah. Okay. And who the heck saves for 6 months or 12 months? There are people out there like that, but not many.
Absolutely. But you make a very good point that this is going to be an opportunity for anyone who, and folks, I'd like to apologize. We have a couple of people who are popping in and out because we're using Dr. Garg's Zoom. So they were jumping in so that they can watch and listen to the interview. Some of them have their video on. We're just turning them off as they pop up on the camera. So I think that anybody who is business-minded, and you and I have spoken at length, you know the way that I think, at least I think you have a pretty good idea of where I come from. I see this as an amazing opportunity, like one that I've never seen before in my lifetime. But I would also caution people to move carefully because we don't know when it's going to end. So we all hope it's going to end soon, but most of us hoped it was going to end a month ago, So what are your thoughts on that? And what are your thoughts going forward as just a business person during this quarantine period and after? And what do you foresee?
What happens is let me give you 2 analogies. Okay. Let's suppose we start at December, January, where not many folks were paying attention to any of this in the US at least. And we're setting goals, like a lot of us set goals, New Year's resolutions. We're setting a goal, financial goals and health goals and personal goals and spiritual goals. And we're setting those for the year. And we said, I'd like to grow the business 7% this year, 4% this year, 12%, 30%, whatever your numbers are. And you set these goals, and I'd like to introduce this X and Y procedure. I'd like to introduce this team member. I'd like to introduce this build out, is whatever your goals are. Okay. And that's great. All right. Is the folks that got on the Titanic, they had goals. They had goals. I'm going to get to New York. I'm going to go have a nice dinner there. Okay. I'm going to maybe visit New York for a year. Okay. Someone is training for the Olympics. They got goals. I'm going to watch my calories. I'm going to exercise 6 hours a day. I'm going to have no fat, or I'm going to have fat, or whatever and I'm going to get that gold medal, silver medal. All right. And the same, we had goals. And all of a sudden that Titanic, it hits that iceberg, and all those goals for that nice dinner should go out the window.
Absolutely.
That athlete that's going for the Olympics, he gets hit in a car accident. All those goals about his weight and about his exercise number of hours and his regiment and it should go out the window. Okay.
Yep.
And now all of a sudden this hits, it's like that. It's like the Titanic. It's like the car accident. Those goals of mine, they're out the window. Okay. The only thing that they're focusing on at that time on the Titanic is survival. The only
Absolutely.
time in that emergency room, that app they should be focusing on is survival. Right. And the only thing I want to focus on right now is survival.
The
How do
thing,
I get
the
through
thing
this?
is, I was talking to a really smart friend of mine a couple of days ago, and you know what he said? He said that the very things that make a dentist a great dentist are what's going to make them suffer through this. I think that might have been someone right here. Tell us what you meant by that.
Is no, was that me? I don't think
It was. You told we were chatting and you said, the thing is dentists are meticulous. Dentists are long-term planners. Dentists are careful, and they want to make sure they're doing it exactly the right way. And that makes them amazing clinicians. And I'm paraphrasing right now, but I thought it was so much wisdom in just one sentence. And you're kind of saying that now, but the background of that is it's true. What makes us careful, good clinicians is also what is going to keep us from making the rapid fire decisions that we need to make as the situation changes.
Well, that's what happens otherwise it's strategic thinking, long-term planning, and, et cetera. And now it's tactical. Okay. It's got to be thinking about survival. Okay. How do I stay alive in this emergency room? Okay. That's what we got to think about. Okay. How do I stay alive for the next 6 weeks or 8 weeks because no matter how much you cut your expenses, there's still some expenses we got to pay. I got to pay for the internet signal so you and I can chat.
Mm-hmm.
I got to pay for Netflix so I don't go crazy. I don't think the electricity people are going to cut me off. Okay, at a time like this, I don't think the city's going to cut me off if I miss a couple of bills. So, I'm just not paying those. Okay, I don't think the city's going to send people out under COVID to cut off my water. So I'm not paying that. I call the credit card companies because I'm sure they'll cut me off, but I got other credit cards to use. But just to be polite, I called every single one of them and said, hey, can you defer payments for 60 days? Okay, and they said yes. Absolutely. And I called landlords. And some of the buildings I own, some of the ones I don't own, I call landlords. And as I think the law was passed, no one can be evicted for 60 days, but I wanted with communication lines open. So I called them and said, can I defer his rent for 60 days? And all of them for me did say yes. I know some people posted on social media, they had really lousy landlords that didn't say yes, but for me, they all said yes. And so I said, okay, how do I get through this? How do I survive? Okay, this has got to be tactical. And survival really means is you got to preserve your cash. Okay, because no matter what, there's still going to be outgoing cash, and there's zero incoming cash, right? And there was some glimmer of hope, is government monies and this and that. And instead of glimmer of hope is, but realistically, we all knew that wasn't going to amount to a hill of beans. And it's almost funny to me when people
you have as much faith in the government as I do.
Yeah, and realistic, is people talk about the government giving money. I'm like, well, the government's not giving me money. They give me a fraction back of what I gave them. Okay, last April 15. Okay, so Absolutely. They're not giving me money. If I gave them this much, they're giving me a teeny bit of a back. Okay, of my own money. And we're all seeing that. The EIDL at a maximum cap, it was $10,000 supposed to be for every office, then they changed it to 1,000 per employee.
And you were going to get it within 3 days. You remember that? 3 days.
Now it's 3 weeks, and it's 1,000 per employee. About half the practices have gotten it. But when you got 3-4 employees in the office, you get $3,000-$4,000, and used to collecting $50,000 a month. It's a fraction of what your normal collections are. Still good. I mean, better than nothing. People applied for the PPP, and some people are starting to get that. Okay, probably not half. Maybe 10% of dentists have gotten that.
Right.
But right now, they think that part of it will be a grant that they will not have to pay back. Part of it they will have to pay back. But that's how did you change? I mean, we may have to pay all of it back. It's just more, but it still allows us to survive through this. We're still able to get through this. And so you get folks like dental offices that have no income coming in, which is majority. It's dental offices, restaurants, bars, bartenders, restaurant employees, is all of these small businesses and all their employees and such have no income. And is you've got folks who make the same income as we talked about. University professors, they're still getting a salary. Is government employees, they're still getting a salary. is and a very, very small fraction actually making more, you know, is the toilet paper companies, they're making more, okay? Is the mask companies, they're making more. So very, very small fraction is in 3 weeks or 4 weeks, probably the divorce attorneys will make more. So there'll be a small subset that will actually make.
I don't know if I have to spend any more time at home with my kids during this thing. I might have to say I might need defense on a murder rap.
Yeah.
I'm not planning on killing my children. For those of you who worry,
maybe therapists will make more.
Right.
It's the majority are going through all of this together. You know, there's a very, very small percentage that are doing better, small percentage that are doing the same, but most of us are.
So Arun, let's speak to a little bit on the historical perspective of this. You know, we have had diseases. Comes to mind, SARS was a pretty minor one. We've had pandemic flus. We've had the AIDS epidemic. I think that's pretty much the closest thing we've had to this, simply because of the amount of misinformation that was out there and the amount of panic. I can't really remember any other ones other than Marburg and Ebola that have elicited this type of visceral emotional response in people. And we've had pretty dramatic downturns, particularly 2001, 2008. 1969 was another little doozy there. And we've had natural disasters, like, you know, we've had earthquakes and volcanoes, but we've never had all this shit happen at one time. And that's what we're having right now. So what is your historical perspective on the behaviors of patients, the behaviors of dentists as business owners? What types of things would you say look for this as an opportunity? What types of things would you say, hey, I caution you because, you know, I stepped in this back in 2001 or whenever, and I'd say don't go there. So I'm just going to open you up to kind of exploring those thoughts.
Well, the one thing is, what you got to do is preserve cash. Okay, I mean, we just talked about that, but you got to preserve whatever cash you got. Is slow down how fast it's going out, because like I say, it's going to keep going out, and we don't know when it's going to start coming back in. You know, is even if we're allowed from whether government regulations or ourselves to do beyond just emergency care, and we are still allowed. Most states are still allowed emergency care, so it's not like offices shut down completely. I mean, I know that's what we talk about on social media, shut down completely, but you know, I don't think people are sitting home every single day, all day long, twiddling their thumbs, unlike restaurant owners, unlike bartenders who might be, you know, is twiddling their thumb. My sense has been that probably about half the dentists are at least seeing emergencies. Okay, half maybe just be sitting home doing nothing, but half are probably still seeing emergencies. But that doesn't pay a lot of bills. I mean, those aren't the high revenue things. And so it still means revenue is down. But let's suppose we're allowed to do elective procedures, allowed to do veneers, allowed to do, you know, implants and these kinds of things in the next several weeks, you know, whatever date it is. Who's to say the patients are going to come in? All right. And then who's to say is that they will have the money or the desire to spend it? Okay. Absolutely. So maybe we need to be strategic about that and say, you know what, is May, June, and July, we'll do a, you know, post-COVID recovery pricing. Okay. And that's not is saying anything about our worth or that I, you know, went to school or I deserve more, but it's just showing my human side. Like, look, man, I know what you're going through. Okay. And so I know what you're going through, and you know what? I want to help you out. I can't do it for free because I got to make a living too. I got to cover my overhead. I got to pay my staff. But you know what? Is for these 3 months, we're going to have a lower fee. Okay. We're going to help the community out. Okay. We're all in this together. Absolutely. So is there strategies we can do like that? Okay. To get folks in and it helps grow our business and it helps us help our community out. All right. And the different thing here is that when other things happen, you know, hurricane comes to Miami, okay, and when it wipes out things, but it only affected folks in Miami. And so folks in Miami, they lose their incomes, they lose their jobs, and you know they're down financially. But the rest of the country's like, oh, we're doing great. Tornado comes, you know, what? It affects them, but not the rest of the country. Snowstorm comes to New York, affects them, but not the rest of the country. But in a way, this is a great equalizer. Is everybody is affected to the same amount, except for the outliers. We said there's a couple of categories that are doing okay and doing better, but the majority of the population, it's a great equalizer. So if everybody is down an equal amount, we're all kind of in the same boat. We come out of this, we're kind of in the same boat as everyone else. And so in that regard, it's actually not so bad. And I say, well, I just got a 20% pay cut, but so did he, and so did he, and so did he, and so did everybody. We're all kind of in the same situation. And so my revenue's down, but then is the price of an airline ticket is lower for me. The price of a restaurant is lower for me. The price of the gardener is lower for me. The price of everything is lower for me. So my lifestyle goes back to the same. My incomes, you see, when you look at when you look at the value of money in different countries, people can have similar lifestyles, even though money is worth less, but then they have to spend less also. So I think in a way, it just kind of devalues things in that regard. Is I'm making 20% less, but I'm spending 20% less on a lot of things. Not everything, obviously. Your mortgage doesn't go down by 20%. It's going to stay the same. Okay, but a lot of things will go down proportionately. So as far as lifestyle, I think we're going to come out of it is similar lifestyle. Okay, even if you look at the bank number, it may seem lower. If you look at production numbers, it may look lower. Okay, and you go, well, the value of my office is less. My value of my house on paper is less. I know, but if you sold it, you could buy another house for less also. So it's still going to be an equal exchange.
This is one of the most positive messages I've heard from anybody who's been out there talking about how to recover. We kind of joked on air before we started on the live that it's interesting how many experts there are on recovering your practice from the COVID quarantine when it's never happened before. It's very impressive that so many people became such scholars in such short amount of time. I think this is the first time I've heard just a very positive message about nullification and normalization of the effects. And you make a very strong point there, I think, and I think one that needs to be made. And we have a couple of questions here. Someone says, won't insurance give us hell if we lower our fees? Another one says, Arun, what about PPE that is so expensive now? And that's from your neighbor, Tatiana Herzog, by the way.
Those are great questions. Okay, let's delve into that. Okay, and we can do them one. We can do one, I guess one at a time. So let's talk about the insurance as part of it. Okay. For those that were there at the beginning, we talked about two different types of practices. We talked about Andy, $4 million a year. He's been working, he's late 60s and they're working for years. And for him, having extra expense of, as far as insurance, he has a lot of options. He could do his next office non-insurance. Okay, he could do complete fee for service. It may take longer to build up patient volume because you have to spend more on marketing. He can't automatically just enroll in insurance plans, enroll in Delta Dental, and all of a sudden he's got some patients, but he's able to afford that. He's able to ride that out. And so he's got that option, go fee for service. Okay, he doesn't have to worry about lowering fees or hiring fees. But if you say, well, I'm not that guy, I'm not the one that is going to go bankrupt, but I'm kind of, a normal, let's say, rich, okay? And he's got a normal PPO practice, 4 days a week. And as normal staff, he's seeing the number of patients you got to see in kind of PPO practice, which is a fair number, and got to turn them around. And the margin that you have, the profit margins got there. And what does he do about the insurance fees? But when you lower your fees, is as far as the insurance, they don't give you a heck about lowering your fees if you're doing across the board and fair to everyone, is my understanding. I don't have an insurance-based practice, fee for service, but my understanding is if you lowered it for different people, then they give you heck. But if you say, we are now dropping them this much across the board to everybody, okay, then you're dropping it. Just like when you raise your fees by $5 or drop them by $5, as long as it's fair to everybody. Okay, they say you can't pick and choose and say it's this fee for insurance patients, this fee for service patients. You got to drop it for everybody. Okay,
and having come from a PPO background, what I can tell you on that, as I'm now out of network and have been for a few years now, is that if you want to discount the price, what Aaron is saying is you discount for everybody, period. But if you give them vouchers that are coupons that they turn in, there is a legal loophole there so that you can use that. And, you know, if you got the pain in the ass patient that you don't want to give one of those coupons to, that's just fine.
Yeah. So there's definitely loopholes, but if we're dropping it for 3 months and saying we're doing a special to help out our neighbors again, that's not is my forte PPO, but my understanding is that would not be an issue at all. As far as the increased cost of PPE, I think right now we're having a knee-jerk reaction about how much PPE we're going to need. Is long-term, there may or may not be an increased cost of PPE. Okay. We think about is PPE is if you're wearing a gown anywhere, you're going to be wearing a gown. You're wearing a surgeon's mask anywhere, you're going to be wearing a surgeon's mask. Okay. Right now, there's a lot of talk of the N95 mask, but that may not become the standard. Using N95 mask is one per patient. Right now $6 a piece is per patient.
Right.
And so don't be surprised. Right now it is. I mean, people are like, oh, I'm going to N95 and a surgeon's mask over it, okay, and a respirator to breathe, okay. But that may not become a standard. A face mask. A lot of folks use face shields anyway. In my Aventura office, Dr. Rezakani, she's been using a face shield for years. What extra cost is there? Or nothing. So I think the increased cost may turn into negligible. I think it may turn into things like and I've already ordered these. Is we got the intraoral section, and it's getting everything that is right there where and you might have two. You got a saliva ejector for the saliva. You got an intraoral for right where you're operating, doing your surgery or doing your tooth prep right there. But the stuff that's come out, so an extra oral. So now instead of 2, we got 3. Saliva ejector, intraoral right there where you're prepping the tooth, and an extra oral here. Right. I ordered them for every office. Okay. And so I just kind of jumped on that, and I figured even if the help it does is not 100%, if it's 90% or 80%, from a marketing perspective to my patients, to my staff, and why do I need those aerosols? Air filter systems, we've always had them in all the practices. Anyone that's been to our office or our courses, our live patient facility in Dominican Republic, we've always had the air filtration systems, and they're inexpensive. And so I don't think we're thinking about a lot of per person costs. So the air filtration system we had for years, not because of COVID, but because we want cleaner air for ourselves and our staff and our patients. Right. And now, maybe the benefit is, wow, we're going to breathe cleaner air all day long is from it.
I tend to agree. I think that, in all honesty, if you look at the filtration of level 2, level 3 mask, it's the same as an N95. I don't think it's going to become standard, particularly since the N95 is not a good face fit anyway. Coming from an industry long ago where we had to have fit tests and banana oil to make sure our masks weren't leaking because we're working in toxic substances. It's simply, it's a halfway mark that really isn't terribly effective. What I envision is probably whole office air cleaners, perhaps some intravent or intraductal UV lamps to just increase the sterilization of the air that's flowing. Maybe the extra oral suction. I think probably a lot of people who have isolites or Kona adapters, they're going to be proven to be just as effective or more so. But it's understandable to react like that to the unknown. Unfortunately, there's so much hysteria right now that no one knows quite which way to jump. Right. So we have 2 more questions here, Arun, and one does deal slightly with PPE, kind of in an offshoot fashion. Many patients will lose their insurance, so expect to have less patients. And that is something that has been discussed as people cutting benefits so that they can recoup some of the losses. Another one says, I think most of us will be increasing fees commensurate with what most others experience in their area and with inflation, mostly due to PPE. So I think we've probably covered that with the PPE. Would you like to talk a little bit?
Okay,
go ahead.
But we can one says folks losing is insurance things, and for the person that's an insurance-based practice, that's scary, because if you say, well, 10% of my patients can't come back, or 20%, or God forbid, 50% can't come back, but it may turn out to be a blessing in disguise.
Yeah, what an opportunity! Yes, set up an in-house finance plan or an in-house savings plan, please.
Okay.
Guys, it's fantastic.
You can't call it insurance because an insurance
Right.
industry is such regulated, but it's in essence your own insurance plan. You know, the Dr. Bob Smith insurance plan. You can't call it an insurance plan, so it's called in-house savings plan. But now instead of they pay premiums, the insurance company keeps 90%, passes 10% to you.
Right.
They pay the premiums, you keep all of it. Okay.
I love savings plans. I think they're amazing.
It is it may turn into a blessing, although it's scary, of course.
Absolutely. Dr. Ben Villa has an absolutely fantastic question. And I'm going to actually tag one of my own onto it. He says, from a traffic perspective, how do you intend to manage hygiene? And I'm going to say, from a patient entrance perspective, what changes do you see occurring? Do you see COVID testing chairside to allow patients to come in and actually be treated? Do you see people not being allowed to be treated if they have only one of the antibodies? They don't have IgG and IgM. Or are you expecting people who don't test positive for either antibody to be turned away because of dangers of getting them infected? What are your thoughts on this?
I think is well, those are two separate questions. One about the dangers,
Yes.
and one about hygiene flow. Hygiene flow will become interesting because they don't have a minute to spare. No, okay. I mean, they're turning the room, boom, 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 and they're the ones creating all the aerosols, or most of the aerosols. And whether that's a legitimate thing or not, okay. I mean, long term, if this thing fizzles out, etc., whether it's legitimate or not, the perception might be, okay.
Right.
And so you'll have to have time in between. Now there's two ways to do it. You do time in between. Instead of 1 hour appointments, you make 1.5 hour appointments. Well, you got 33% less appointments in a day. Okay. It is less of a profit center for you if it was a profit center for you. Okay. What we have done in most of our practices, even prior to this, okay, is each hygienist had 2 rooms. And so she would alternate rooms. And we did it not because of COVID and such. We did it because instead of having the hygienist clean up and set up her own room, we had an assistant for the hygienist. And so because assistant cost us less, much less. And so that person's time was being used for room setup and room breakdown. The hygienist would go next door, just as you and I do. Okay, the doctor, we don't break up and set up our own room because our time might be $100 an hour. Well, and we said, well, the hygienist for $35 an hour is worth it for her. Well, it wasn't worth it. Let me get a $10 an hour person, a very entry-level assistant, and let the $35 an hour person do what is productive. So I think we're going to see more of that.
If anyone can find a $35 an hour hygienist, please send them my way.
but that makes the point even more relevant. If the hygienist is
absolutely
more than that,
does,
then why are we having her take up any amount of her time setting up and breaking down the room? The more expensive the hygienist is, the more expensive room setup becomes for us. Okay,
I completely agree.
If you think about the cost savings, I can have her see the same number of patients per day, all right, if I give her 2 rooms and an assistant. Okay, so and now one of my offices, I haven't done that because we just didn't have enough number of chairs. Okay, so that one is I bought an existing office. There was no room for expansion, and so the others we designed ourselves and put in the right number of chairs. Is this one? So that one we don't have her use 2 chairs. So I think I'm gonna see that. Office, I don't have an option there. She's going to have to get more time. You don't have to give her.
Did you ever end up buying that office up in Dallas that I told you about?
I did not buy the one in Dallas, but I did buy one in Phoenix, Arizona. Mm-hmm. And that's a 10-chair office and actually has a 30-person classroom as well. So it's as a practice / training center. Yeah.
Very cool. So we have another question here. And there was one thing I wanted to say with PPE that I'm going to bring up after I ask you this one, give you a couple of seconds to think about it. How do you recommend scheduling patients to make it the most efficient and productive? And I've got some ideas on that as well. But so far as the PPE goes, I think one of the major changes we're going to see that I didn't bring up and I forgot to is the utilization of either wall-mounted, hand wand, or in some cases in the larger hospitals, actually like a Roomba kind of mounted system for UV. There are a couple of those robots out right now. They're programmed to go in a specific pattern so that they sterilize the entire room. The nice thing about UV, and the reason that I believe that UV is going to be the way to go, is because bacteria and viruses and protozoan even, they don't actually have any kind of mechanism which they can use to become immune to UV like they do with antibiotics or even cleaners. Because those of you who don't know, my minor was molecular and cellular biology, so I know a great deal about genetics and bacteria. So my thinking is anything that breaks the cysteine bond is going to kill them no matter what. Anything that screws up their DNA is going to kill them. And it actually penetrates water droplets. So that's my call. If you're looking for something to invest in, I'm going to tell you right now, I think it's UV. But, so how do you recommend scheduling patients to make it the most effective and productive, Aaron?
Well, you gotta have more time between them. The main office that I work out of is right next door. It's in a high-rise building. Right next door, there's an ENT guy, and super nice guy. I've known him for years. And I pop over there. I travel a lot when I fly. Sometimes my ears get, is from the going up or going down. I want to go get them checked and make sure there's not wax or something build up in there. Now is a PPO practice. So he's got a big waiting room, 20 people in there, and it's ENT. So they're in there with colds and sniffles, and this is all pre-COVID. And even then, I would see these 20 people with colds and flus. I'm like, I don't have a cold or flu. I just want to get checked if I got earwax or not. And I would call the reception. I'd check in. I say, you know what? I'm going back to my office. Could you please call me when it's my turn? Because I don't want to sit around with them. All right. And I thought about that. I thought, before it was just me being a little OCD about this. Mm-hmm. Now I think a lot of folks are going to be like I was even before pre-COVID.
I agree.
They're not going to want to be sitting around in waiting rooms like that. So we're not going to have, waiting rooms of 20 people or 10 people. It might be 2 people. Okay, here and there, maybe 4 people. And there will have to be more gaps. Before, the practice management folks would train us to put things in as tight as possible to maximize the efficiency, maximize the revenue. And now we'll have to go the opposite of what those guys said and say, you know what? Maybe maximizing revenue is not the main focus right now. Mm-hmm. Maybe our main focus is doing the best for ourselves, doing the best for our staff, doing the best for our patients, and keeping a reasonable time to turn things around so we're not bumping all into each other.
I'm going to challenge you on that one slightly. I think we're going in the same direction though. The reason that my practice got to where it did is because I listened to everything that Bruce Beard said, and a couple of other guys too. Everybody who ever talked about scheduling by production, and that is how I've always run my practice, or at least since I got out of PPO. So basically, the idea is you schedule very few patients a day, which is what we need to be doing, but you schedule them into productivity slots, and you don't schedule the patient unless the productivity hits a certain slot. It gives you great control over your schedule. And it also makes sure that you have plenty of time to turn the rooms around between, and you're not rushed with each patient. And I think that to a greater and greater extent, what's going to happen is that patients are going to want to come in and get all their work done because they've now experienced this dental shortage. And you're going to say, okay, we can do that. And we'll only be there with you. And we're not going to be rushing off, and we're going to take great care of you. And that's going to help a lot of people to go out of network, because once your patients begin to see you as a caring provider, instead of just the guy who rushes in, jabs in the face, leaves the room, comes back and drowns them and then takes all their money, I think that you're going to find that you're going to have much better patient interactions. You're going to be more profitable, and you're going to have more free time. People ask me all the time, how do you have the time to get on Facebook so much and run a group of 21,000 dentists? This is how.
Yes, absolutely. Okay, more and more fee for service is you do one patient in the morning, one patient in the afternoon, or whatever. Is one patient first part of the morning, one patient second part of the morning is, and then you got plenty of time. And do is a maximum amount of one time.
And I'm gonna plug Arun here. Go take his implant and PRF courses so that you can produce more per hour.
Yes, of course. You got to produce more per hour.
And someone else, Nathan Bloom, is asking, should a solo dentist consider selling to DPOs or DSOs to get debt free? Will there still be a place for the solo practice post-COVID? I'm going to let you handle that one, Aaron. I have some very particular leanings myself. So
will there be a place for solo practice? I think absolutely. Is if you're saying, well, will solo dental practices that go the way of solo pharmacies, and they all come under Walgreens or CVS or something? No, will they go is this is a different animal. There will be a place for that. I think it would be more like, think of not as a pharmacy, but more like a restaurant. Will there be chain restaurants? Yes, there will be McDonald's, and there will be Burger King, and yet there will be lots of restaurants, lots of mom and pop restaurants, and lots of superstar restaurants doing very, very
Absolutely.
not during COVID, but pre and post COVID. Look at the haircut business. Yes, there are supercuts, and there's the hair cuttery, and there's other chains like that, and yet there's lots of haircut places you can go to. So
Absolutely.
I think looking at that model is more accurate than looking as a pharmacy where they all got rolled up. And then you look at like veterinarians, they don't get rolled up at all. You look
Absolutely.
at other industries, plastic surgeons haven't got rolled up at all. There's no really big group out there. Is dermatology haven't got rolled up at all. Orthopedic surgeons haven't. So in some industries you see very little of it, like orthopedics or plastic surgery. Some you see in pharmacy, all of them. But I think for us, it will be more like restaurants and hair cutting places where there'll definitely be those folks. Okay, they're here to stay. There's no way that Ruth's Chris is going out of business. Is obviously okay. That changes.
I'll give you a point for that one.
Yeah.
That was a nice little joke sneak in there.
But there's no reason that the restaurants in that area are going to go out of business either. No.
Excellent. And so for my part, the first part of the question was, Nathan asked, should we consider joining a DSO or a DPO if we are in a lot of debt? And frankly, the answer is yes. You should think about it. But what you should do is you should weigh your options, weigh your business plan, decide if it's the right path for you. And if you do decide you're going to join one, talk to people who have joined that specific DSO or DPO, ask them what their experiences have been, and see if it's the kind of culture that you want to be a part of or that you want to bring your team into. A lot of people consider their teams their family. And recently someone said something really wise about that's probably one of the problems with dentistry, because you let your family get away with a lot of shit that you wouldn't let your employees get away with. But with that aside, the truth is we do consider them our family members. And so think about, is this somewhere I want to bring my family? Now, personally, for me, the answer was yes. But many of you know, I predicted there was going to be a recession. And I didn't predict COVID, but boy, was I lucky that I sold when I did. And I think a lot of other people, I see Glenn Vo just made a comment right here. And he actually sold at the same time I did. We were kind of in it together. So that's my take on it.
Right at the peak. Okay, that was the time to do it. That was the peak.
Absolutely. So we've got another question here. It says, I see you guys are talking about PPO and fee for service. However, I have a 75% Medicaid and state insurance practice. Any thoughts? The profits are driven by volume, 10 to 18 per day, rather than fewer patients. Should I just give up on 75% of my practice? I'm going to say, and Aaron, please feel free to disagree with me here. I think that of all the models, yours is going to suffer the least and grow the most. Now, reimbursement wise, I don't want any part of that discussion, but I think you definitely will not be hurting for patients. And if you're already set up well as a Medicaid practice, I think that maybe with some streamlining, you could do a very good job. Maybe stagger your ops for the time being, at least until the scare is done. Hygiene in every other op. That way you don't have to worry about 6 feet for sterilization. Maybe, as Dr. Vila was saying, stagger your case days where you do hygiene one day and you do only operative the next day. I think there are a lot of different ways that you could approach that, but I think that if you're set up for that type of world, that type of lifestyle, I'd shoot myself in the face. No kidding. But if you are that kind of brave soul who is that giving and you're set up for that type of model, I think you're going to do just fine. Arun, am I smoking crack?
No, I think so.
You think I am?
I see a lot of folks. I think a lot of folks I've seen folks saying, hey, maybe we could lobby the insurance industry to pay us extra for PPE. And I laugh at that. They're not in the business of paying you extra for PPE. They got to try to figure out how to squeeze you more. But the one place you might actually be able to get reimbursement is government types of things. So if you got a Medicaid practice, which of course a government program, that's where you might be able to say, okay, we need an insurance code for PPE. And that now becomes something billable and that becomes something payable, albeit at their low prices. but that you may be able to. So you might see that happening, okay? So there I would focus on trying to get higher reimbursements based on being able to bill for things like that.
Fantastic. Okay, so Dr. Vila has another great question. Ben, you've got the greatest questions, man. What are your thoughts on all on X cases? Should we be focusing on snap indentures right now? Offer more flexible finances? By the way, your FAIR book is amazing.
Oh, okay, thank you very, very much for the book. Is comment is that's on the clinical side of things, how to do the surgery, how to do the prosthetics. Is as far as charging for those procedures. No, I don't think you would change your treatment plan on it. I think what you might do is change your fees on it for 3 months. Okay. Want to get back to the community, want to help out, for May, June, and July, or April, May, June, or whatever, whenever we're allowed to. And you may want, and as you know, the nice thing is that's something that has the latitude. Okay. Because say, well, I don't have any margin on my composites. I can't really adjust my fee no matter how nice of a guy I want to be for the community. And you don't.
Right.
But on that, all on 4 type of thing that we call FAIR, full arch implant rehabilitation, is you get tremendous margin on that. I mean, for folks that aren't aware, is 1 visit for the surgery and a screwed in temporary prosthesis. It's probably about 3 visits for the prosthetics, so 4 visits doctor time. The cost is 4 implants. These days implants $200 a piece at $800. Specialized abutments and transfer copings and such. Maybe it is another $600. A pre-made denture, a couple $100 so it's $1,500, and then the final prosthesis, so maybe $3,000. So it's about $4,000, $5,000, $6,000 a hard cost, and it's usually gone for $25,000. And so it's $20,000 for the doctor left over. Over 4 visits, it's $5,000 profit per visit. And I know there's rent and there's other things and staff and et cetera, but you've got the latitude to say, you know what, we're going to give 25% off. We're going to give 20% off. Instead of what we used to be charged $25,000 for these 3 months. If you make a decision now and do the financing now, we'll do it for $20,000. In September, right. It's going to go back to our normal fee. Okay.
Absolutely.
And I think there are a lot of people that would be willing to say, you know what, some people say, you know what, I bet the guy's going to keep that lower fee in September. Some people say, I'm not taking that chance. If I can save $5,000, I'll do it.
I do a perennial like that. My birthday is in January, and I just make an announcement. Dr. Huffpower would love to see the whole world smiling. If you feel like you can't smile because your dentures fall out or you need new implant retained dentures, Dr. Huffpower is giving you a gift for his birthday for the month of January, X% off. And it works out really well. You get some pin up demand, but that pin up demand always comes through in January, which, let's face it, sucks. Otherwise, if I could figure out something for October and September, I'd be really jazzed, So we have another question, and it is, what do you suggest in regards to staff salary management during the interim until the schedule turns back to normal?
I'm not quite sure I'm following. You're saying, so if I'm closed now, let's say, and because of different scenarios, some people are seeing emergencies, about half are seeing emergencies, some are not even seeing emergencies. So let's take the ones that are not seeing even emergencies, just sitting at home. So you're sitting at home, you got a staff member that used to make $20 an hour. What do you pay them? Well, I mean, 20 times 0. Okay, with 0 hours in the office, it's 20 times 0. Okay.
Right.
And then if you say, well, if we're allowed May 15, I'm going to start back by not 5 days a week. I'm going to start back 2 days a week. And so we're going to work 6-hour days, not 8. I'm going to work 12 hours when it's 12 times 20. I mean, it's a very easy solution. Okay. And then when it gets to 3 days a week, it will be, 20 hours times.
And my feeling is that the extension of these unemployment programs is going to go on for quite some time. Whether you believe that this is going to be an immediate bounce back, or you believe there's going to be a dead cat bounce, or if you believe that there's going to be just a prolonged recession or even a depression, no matter what, the entire country, as Arun was saying earlier, we're all in this together. And so what affects one of us is going to affect us all, which means there will be government programs that get extended, just like there were for Harvey and Katrina, and they'll probably be as poorly managed, but if your employees can go on partial unemployment, that's probably a good idea. Okay.
Other question?
This is a fantastic question. Let me see here. What do you guys think? How should startup practices proceed post-COVID? And yeah, Jenny Apakin, I agree. You should only sell if that is the right fit for you. So, Arun, what are your thoughts about practice startups post-COVID?
So this is a practice that was scheduled to start in April, or scheduled to start in September.
I believe that they're asking, what do you think practice startups are going to be like? Like let's say brand new practice startups, you just graduated dental school, you graduate post-COVID.
Right.
What is the startup process going to look like?
Oh, I think it's going to be very similar.
I would agree.
Yeah, starting a new practice was always a little bit scary and is always a little financial risk. But when you get your loans, you get the loan for the practice, and you get a working capital loan for the first 6 months or first year, because no one expects you to start turning a profit right away. You may not need it, but it's better to have that cushion. And so you have that cushion but what happens is when times are good, the top guys that have great clinical skills and great communication skills and great thought process, of course, they're doing fantastic. But even the mediocre guys that have kind of medium skills and medium communication ability and medium is thought process, they're even doing fine. And even the guys that don't have such good clinical skills and not good communication skills and not good thought process, even they're surviving. Okay. When times get tough, that third group is done. Okay. Is Warren Buffett probably the richest guy on the planet, or certainly one of the top 2 or 3 richest guys on the planet? Certainly the best investor ever is in the planet. His saying is, you never know who's swimming naked until the tide goes out, or you can see who's swimming naked when the tide goes out.
Yeah,
okay?
Absolutely.
And what that means is basically it's during the tough times you see who had those. So if you say, well, I have a good thought process and I got good communication skills and I got good clinical skills, then your survival skills and doing well skills in a startup are the same as they were before. Numbers might be lower. When people used to talk about a million, they won't talk those numbers anymore. But you know what? Right. 10 years ago, we didn't talk that way. 20 years ago.
20 years ago, it was how to have $100,000 dental practice.
Yeah, is when I was first out, there was maybe one guy in the country that $1 million a year. I mean, that was like, huh? What is he making up the numbers or like that? And now it's like, $1 million. You $1 million.
I can't remember his name. He's the guy who does all the veneers out for the Hollywood stars. What was his name?
Bill Dickerson. Yes, Bill Dickerson.
Yeah.
Okay. But so now what happens is if all the million we drop to 800,000, we're all in it together. Okay.
Right.
So the startup practice started 3 years ago might be doing 500,000. You're going to do 400,000, but your expenses will be proportionally is lower, or should be, and you should be looking for that. The build out, just like you're hungry, the builder's going to be hungrier. The same build out that he might have given you a estimate of 350,000 for, 6 months ago. Now I say, you know what? And he said, I can afford 250,000. Nope. You know what? Now, remember that $250,000 offer you made for the build out? I'm ready to take it. Okay. Yep. So I think you're going to do fine. Now, if you're in that third category, poor clinical skills, poor communication skills, poor thought process, then you will be lost in this current climate. No. Okay. Yeah.
So I wanted to make a joke there, but some of my friends would get mad about where they could go work, but I can do that. I get lots of nasty messages whenever I make a joke like that. So he says that he's going to be starting up in April, which I have to say, I feel for you. It's going to be a very, very tough time. But hammer through it.
Tomorrow he's opening up. Okay.
Evidently.
Yeah. Is what I would do right now is market aggressively. Okay. For emergencies. Okay. Is obviously, I don't know what state you're in, and some states might be open for elective or near opening, and some may not be. But for emergencies, most of the states are open, and I would market aggressively for emergencies and get those emergencies in. And because half the doctors are not seeing emergencies, about half are, but about half are not. And is for those half that aren't, they're patients that need somewhere to go. And if they have a true emergency, and I'm not talking about wink, wink, taking patients. I'm not talking about a patient that's been going to another doctor for 8 years and got a little chip on number 8, and you grab them and say, I'll do your, because to me, it's an emergency, wink, wink. No. We're talking about legitimate emergency. The guy's got a tooth that's blowing up. It's hot. It's in the socket. He can't chew because if he chews that one tooth that's super erupted, okay? And if you've never had that happen before, believe me, okay? I was in Hawaii at a lecture, a tooth fracture, got a vertical fracture. I'm like, fine. By the time I'm on my way to the airport, I was flying from there to Frankfurt, Germany to go there for a week, it raised up, and all of a sudden I couldn't eat on any side of my mouth because I was gonna be on liquid diet for a week. And I would have done anything. I would have paid anybody. In fact, I did. I changed my flight to go Hawaii, San Francisco, Germany, and met up with a buddy of mine, went to his office, and got a pulpotomy done, and occlusal equilibration done. So real emergencies, get those folks in. Okay, it's a real help. You're not stealing anyone's patient. It's win-win-win for you, win for them. Is I would focus on that. Okay, get them in.
Absolutely, I completely agree. I'll tell you, I don't know what your age as a clinician is. The longer you've been practicing, and the more you practice as a comprehensive dentist, the more quickly you'll recognize issues in a patient's mouth. I'm not saying to go ahead and do a full comprehensive exam on each one of those patients, but I like to tell my patients, hey, if you don't mind, I'm going to look around at everything else before I look at the tooth that I know is hurting you, because I want to make sure that we can spot any issues that may be coming up, because let's face it, we never want to meet like this again. And the patient goes, yeah, sure. Hey, look, this tooth right here has got a fracture. It's going to break. We need to make sure we get you scheduled for that as soon as we're able to do comprehensive treatment. And if it happens before then, I'll make sure I rush in to take care of you. But it's in their mind, and they're thinking about it the entire time that they can't get what they want. Usually they don't want dental treatment, but whenever people are kept from having something, all of a sudden they want it. And I think you're going to find that there's going to be an explosion of demand as soon as that we're out of this.
I can tell you
thoughts on that.
I have a lot of colleagues, dental colleagues, and a lot of alumni and such, and they're all my favorites. I mean, I love my profession. I love my colleagues. I love my alumni. After that appointment in San Francisco, I had a new favorite dentist, the guy who took me out of pain. Okay?
Absolutely.
That was my new all-time favorite. All right, I can tell you. And I laughed about it. And using my own experience, I came back and I told all of my associates, I said, you know what? Anybody's ever in pain, you get them in that day. I can tell you from personal experience,
Absolutely.
They will be grateful for life, because I was grateful for life. Okay, even being a professional, the consumers, okay, get them in. Okay, take care of them.
So we have a question here that's not something that we were really going to cover, but they're asking it, so I'll ask you. Can you talk a little bit about the IDIA, mastership and diplomate, etc.? I think that probably we don't want to go too deeply into that because it'll get very clinical very quickly. Yeah. But I would say that there's a very definite business argument, even if you use the argument, more letters don't mean more knowledge. They do in patients' minds. Talk to us a little bit about the mastership. Talk to us about the diplomate. I'm assuming this is the Indian Dental Implant Association?
No, it isn't. And I won't talk about it other than just to kind of clarify it. Okay.
Okay.
Because honestly, I'm here is to talk about business and talk about this. I don't want this in any way, shape, or form to be about me or an infomercial for any of my businesses, endeavors, or anything. And I appreciate the comments along those. I'm happy to talk to folks one-on-one about it. I have no place to go but talk to people. So
right.
I've got nothing else on my schedule. It's the International Dental Implant Association, and it was founded 10 years ago, is up to 4,000 members, and is not the largest dental implant association in the world. It is the second largest. Okay. It is the fastest growing by far. So the fastest growing by far, and the second largest in terms of size, and has 4 symposiums a year, is all over the country, and has a program where you can earn a fellowship, a mastership, and a diplomat based on number of cases, based on written examination, based on oral examination at each stage. And I'm happy to talk to folks separately on that. The website, just International Dental Implant Association.com, is a big long name.
You know, actually, I think that would make a really good, I think it would be a great podcast episode, just having some people on who are diplomats from different societies and just talking about that. I am going to ask you one question, if you don't mind answering it. Is that diplomate legitimate so far as the specialty recommendations of non-ADA specialties here in the United States?
Yeah, it is legitimate to use a diplomat status. You've got the written exam, you've got the oral exam. In terms of recognized specialties, what most of us grew up with was things like periodontics and oral surgery and orthodontics and such. And then for several decades, the ADA didn't recognize any new specialties. And then lately, they recognize a ton of new specialties. Is oral maxillofacial radiology, a 3-year full-time residency program, has been recognized as a specialty. Recently, several others got recognized as specialties. I didn't even keep track. Kind of niche, very small niches, but I think facial pain and TMJ is therapy recently got recognized as a specialty. And so
dental anesthesiology.
Yes. Okay. Dental anesthesiology got recently recognized as a specialty. Dental implantology hasn't, and I don't think it ever will, because there's too many crossovers with perio and pros and even endo and oral surgery, and so that probably never will be, because there's too much politics involved. But as far as marketing it for your practice, marketing with your name and marketing as initials, absolutely you can do that legally.
Excellent. Well, here in the state of Texas, if you have a diplomate, I know the ABOI, if you have a ABOI diplomate, you can advertise as a specialist in implantology. And if I'm not mistaken, doesn't Loma Linda have a specialty program there for that?
A number do. You know, I used to do it when I was at University of Miami. We used to do a 2-year full-time specialty program in it. As Loma Linda did and still does. I think in New York they still do, and they take about 100 people a year for it. And so there's a number of training programs. Yeah.
All right. Well, so folks, there's your answer. Let's see here. Final presentation. Finally, a presentation that's not doom and gloom. There you go. Any temporary pay cutoff to staff? What is the recommended percentage? Man, that's going to be based. I'm pretty sure we just covered that.
Well, let's talk about that. Let's talk about that. Okay. That's something to talk about. Okay. And, there's nothing, no doom and gloom until now, maybe a little doom and gloom. I'll tell you what I did, and whether it works for me or not. There were people that I just hadn't gotten around to letting go, and it's like, I've been thinking about it, and they're like, family, I don't want to, and I get busy and I use that as an excuse, etc. Well, I can tell you, not everybody's getting hired back. I can tell you, not everyone's getting hired back. Okay. So my payroll costs will go down. Okay, because the people I've been thinking of, you know what, is I didn't have to fire them. They're just not being invited back.
Absolutely. I wanted to tell you, I was so excited about your new opportunity. What new opportunity, Dr. Garg? The one somewhere else. I know I'm a mean guy. I actually enjoy firing people, and like a lot of people, I really, really enjoy it, because at the time I fire someone, I've already documented so much shit that I'm thinking about it all the time. And I'm like, are you going to do that thing again? Jeez, they did it again. And I'm just waiting for the right number write-up so I can fire them without having to worry about getting unemployment claims. So by the time I come around to firing somebody, they so deserve it. It's just, I know I'm going to come to work the next day like singing hosannas. It's going to be amazing. Maybe that's just me.
The second part of it is, I think this is what the question may have alluded to. There may be some folks that you need to hire in a new capacity at a new salary as well. So some people may not be invited back, and some people you may need to reassess, and you may need to say, you know what, is this salary level is not appropriate. The position level isn't appropriate, and I'd like to hire you back at this salary level. And
absolutely,
you may need to do that with some folks.
And I think that that's an entirely appropriate thing to do as well. There were a couple of questions earlier, and I was really hoping that someone was going to bring this up. But they said, should you hire all your people back at lower salaries? And the honest truth is, God's honest truth is, we were in the single lowest unemployment period in history since 1969. All right. That means that wages were at their absolute maximum that they're going to be, because that's the effect of low unemployment. For those of you who don't study economics, that's the effect. It's a natural effect. So when you have higher unemployment, it's absolutely appropriate to normalize those salaries and that pay rate. If you want to speak to that too, thoughts and protocols. You're getting a call.
No, I'm going.
Okay, so what are your thoughts on that? Normalizing.
Yeah, I think you just said it, but absolutely. If there's some people that you need to adjust, and then so I think there's gonna be three categories: some people that don't get invited back, some people who need an adjustment in their salary, and there's some people you may not adjust. You may keep it the way it was. So you have three different categories.
We have somebody who just asked a great question. What are your thoughts on what protocols do you use so far as teledentistry goes? And specifically for me, how in Texas do you use it without crossing hairs with the TSBDE? And I'll tell you, you don't get paid for it, or you will be in trouble because they have specifically said no teledentistry. But if you think about it, anytime someone calls in and you're not in the office and your team member says, Dr. Huffpower, Miss Susan Smith, she's got a toothache and she needs you to send some antibiotics, and you do that, you've just done teledentistry. So I think that there are some things that you can get away with, some things you don't. I hate to say get away with, but I think sometimes some things are going to be considered to be all right exclusions to teledentistry, and that's one of them. But I don't believe that you're going to be able to actually do treatment plans. Now, you may look at photographs and you may say, you know what? I think you're a great case for orthodontics. Come on in, we'll look at you. Or you know what? I think I can fix those teeth that you have missing with some implants. Why don't you come in and let us take some x-rays and let me do an exam? I think that's appropriate. And that is actually a really good idea. Dr. Garg?
Good. I think we've always done teledentistry. Okay.
Right.
We just didn't call it that. We just didn't try to figure out codes and try to bill for it. We've taken phone calls from folks. We might've taken FaceTime calls, and as we called them back, I mean, that's what teledentistry would have been, is we just didn't think to charge for it. It was included, I think this is just a way for people to try to figure out a way to get paid for what we've always done.
Absolutely.
I don't think it's going to go anywhere in terms of trying to get paid. We're surgeons. Okay. You could work at a different business. I mean, you could say, well, can I get legal advice over this? Maybe you could. Could I get accounting advice? Maybe you could.
Absolutely.
Could I get a webinar? Maybe you could. Okay. There are certain industries where that would be appropriate for. But for a guy who's a certain guy who works with their hands, it's construction. I like to do teleconstruction.
I was gonna say exactly the same thing.
I'd like to do tele-restaurants. Well, it doesn't work like that. Right. And so in our industry
So I hope everyone enjoyed the souffle. You're feeling full? I don't know. Stop licking your screen. So Jennifer Marin Crystal, the UV robot that I mentioned is put out by uvd-robots.com. I'm going to say it's probably too expensive for a dentist office, but I could be wrong. You can go to their website. Again, that's uvd-robots.com. I have no financial interest. It's just something really cool I saw as I was researching what the hell we're going to do after COVID. Okay. It looks like that may be the end of our questions. Guys, we're going to chat a little bit more just about some normal BS, and you guys go ahead and pop on any questions that you have. We're going to give this thing another 2 or 3 minutes. And if we don't get any great questions, we're going to go ahead and shut it down. And then, Jennifer, I didn't mean to make you sad. Don't frown like that. Then we'll discuss maybe doing a podcast sometime in the near future and get some of your questions that you'd like to ask as well. So, everyone, we've been talking about COVID this whole time, right? We've been talking about what are you going to do whenever we come out of all this, and what are we going to do to open our practices, and how are we going to deal with the fact that the sky is falling? I'm going to ask you a very pointed question. I want an answer because this is not a commercial, but I'm inviting you to answer. When do you think your next implant continuum is going to be, your next travel one?
my timeline is this, and things can change on a daily basis, as you know.
Right.
Okay, is our timeline is this for our employees for the seminar side. We're planning to head back to the office and functional May 1. Okay, is for my clinics is I've spoken to the clinic team, and we're planning to do more and more is May 15. And again, that may change, and we may not be open for elective by then, but that's our plan. And then for seminars where I travel to different cities and such by June 1. Okay, so that's our timeline, and it may get shifted. I mean, you never know. But May 1 for office things, May 15 for clinical things, and June 1 for is on-site, whether it's live patient lecture. That's our timeline for now.
All right, fantastic. Couple of questions did pop up. Are you planning on changing gowns, head caps, shoe covers, etc., between patients when we open, and another, can we see 2 patients at a time? To my knowledge, there's no recommendation so far as seeing 2 patients at the same time. There also has always been recommendation to change your gowns and your head caps. And good Lord, if you're wearing shoe covers, you're going to die, because those things are slippery. I bust my ass in them every single time I wear them, so I don't wear them. But I'd honestly almost rather one of the foot dip pans that you see in in rural sterilization environments. But what are your thoughts on that, Arun? Am I smoking something here, or should you be changing them every patient?
I think what's going to happen is it will become a moot issue, because I don't think you're going to do a lot of side books and et cetera. Initially, when we first come out of this, is the way we're planning it is May 15 to do more and more. Is other than just emergencies right now, is to add a day to the schedule. Okay, we're not coming back 40 hours a week, is right out of the bat.
Right.
And so if we're coming back an extra day a week, okay, right now we're just going in for emergencies, and with 1 full day, is each of my offices open at least 1 full day. And there's no reason to put the patients in that tight if we're there for the whole day. And then we go to 2 full days. Again, no reason to put them in that tight. Then 3 full days, no reason. So I think while this is going on, there's no reason to put them in. And then when we're full schedule, then we won't have these worries. We're going to go back to the way things were. So
Absolutely.
While we have this concern, we don't need to pack the patients in that tight. When we have the demand to pack patients in that tight, by then this will be gone, vaccines, et cetera, et cetera. There's immunities, et cetera.
Absolutely. Well, folks, thank you again for joining us, and spending 45 minutes of your precious time listening to the sound of my stupid voice, and the words of wisdom that Arun had to pass out today. I think to sum things up, remember, no matter how different our realities are, our fears and our concerns are the same. And if you take a cautious, measured approach, take a deep breath, and think, you're going to be just fine. Arun, thank you as always for coming. And do you have any parting words before we shut this thing off?
Good. Okay. We're all coming out of this together.
Absolutely.
Yes.
Thanks again, man.
Thanks for listening to the Dear Doc podcast, your source for the business and legal questions associated with your dental practice. Don't forget to subscribe to the Dear Doc podcast on all major platforms.